Hello, guys. Happy Tuesday afternoon. I hope you've had a great day. If you hear commotion in the background, it's because we've started community groups, and the girls tonight are doing an exercise class in their community group. If you need a community to help support you in your health journey, please join us. We would love to have you. You can email us at contact@clearpathmedical.net for more information on our specific community groups. I hope everyone in my area is gearing up for snow because we're about to get some more winter weather. My kids are super excited because school's already been canceled for tomorrow, even though not a drop has come out yet, that they're super excited. We may be working from home tomorrow. We're just going to wait and see what the weather says, but we'll be able to answer phones and answer messages. So if you're a client and you need to get in touch with us, you can message us through Healthy, or you can call and leave us a message and we will get back with you. So if you remember, February is Heart Health Month, and we've been talking all things heart this month. I've presented some studies. We did a new thing last week talking about heart health and how it connects to female health and that interconnection. The week before that, I did a study that highlighted women, and it showed the biomarkers that were most closely related to cardiovascular disease. And it was a surprising thing for some people because the marker was not LDL cholesterol or total cholesterol. It was actually insulin resistance, metabolic syndrome, things like that. But one of the comments in that presentation when I was giving it was, "What about men?" Well, I didn't think there was a study that was done in men, but I went back and looked, and I actually found one that's not 100% done in men, but it is got more men than women in it. And I want to present that to you today so you can see what the differences might be between men and women, or just between that study and this study. But to remind you that cardiovascular disease is the leading cause of death in the U.S. It's the leading cause of death here in Dixon County and all of the surrounding counties. To be considered early death, which I think honestly any death of cardiovascular disease is too early, but to be considered early, that's 55, before the age of 55 in men and before the age of 65 in women. Now, to highlight last week and some other talks we've had, why do you think women early cardiac disease is 65 and not 55 with men? Well, it has to do with hormones, because estrogen itself is cardioprotective. So we don't really see the rates of heart disease skyrocket as much in women until we go through menopause. Now, with earlier and earlier premature menopause, with changes that, girls starting menstruation earlier, with having diabetes and things like that happening early, I think we're going to see the female age catch up to the male age, which is a very sad thing to have happening. But as of right now, if you're female and you have some estrogen floating around, it gives you some protectiveness from some of that cardiovascular disease. So the study that we're going to look at today is called Associations of Lipid, Inflammatory, and Metabolic Biomarkers with Age and Onset for Incidence of Cardiovascular Disease. This study was just published in 2022, so fairly recent information in BMC, and the link is in the show notes. So if you want to go read it yourself, and I encourage you to go read it yourself, please do. So my first thoughts when I thought back about cardiovascular disease and read about the ages, the 55 and 65, was, wow, that's coming up really close for me. That's really scary. My second thought was, the youngest man in my practice that I've had die of a massive heart event was 35. And that was detrimental to his family. It was detrimental to us as a staff. It hit us so hard to have someone so young die suddenly of a heart event. And man, if I had known then what I know now, maybe I'd do things different, but I can only go with the knowledge that I have. I wish the studies like this had been around back then, because the knowledge has just changed and evolved. So regardless, we have these ages, they're really young, they're catching up with us. What can we do about it? So these biomarkers in this study, it was a little bit different as men and women. Now, in fairness, something else that was different is this study was done in the Chinese population. So it's not done in America. Can we say that all differences between Chinese ethnicities and other ethnicities are the same? No, but what I can tell you is that if you start to see a common theme come up in literature in multiple ethnicities, then it might just trigger you into thinking this is a human issue and not just specific to an ethnicity. And when we're looking at cardiovascular disease, I like to think of it like a forest. And for the last 40 years, we have been focused on a single tree in that forest, be it cholesterol and LDL, and we've forgotten about the forest that's around it. But if you keep seeing the same trees pop up in multiple ethnicities, then they're probably a really big indicator of the forest itself. So last week, remember, or no, 2 weeks ago with women, we found insulin resistance, hypertension, metabolic syndrome, obesity, and a parent dying before the age of 60 of a cardiovascular event. So let's see how this might compare. All right. So this is a prospective study. If you remember what a prospective study is they take a group of people and they follow them for an amount of time and see if the trends pop up. In this particular study, it started in June of 2006, and they followed individuals for 13 years. 13 years is a pretty long time to be followed. They enrolled when they first started. They had 101,510 individuals. Now, the split between male and females, this is what I found interesting, but it's something unique to Chinese, I believe. Males, there were 81,110 males and only 20,400 females. And I think it's more of a male-driven society than necessarily here in the US, and therefore men were signing up more for this study. But I liked that it was predominantly males so that we could relate this information. What they were looking for is they did an initial study or initial survey, and they excluded some people. So if there was any pre-existing or known cardiovascular disease, those people were excluded. And at the end of those exclusions, they still had 97,000 individuals. So this is a smaller study than the women's one that we discussed, but still predominantly male and a fairly large number. And over the course of 13 years, they were looking for first heart attack or first stroke. So they didn't include things like needing a bypass or needing a graft or a stent, things like that the Women's Health Study did. But it's just, did you have a heart attack and did you have a stroke? The baseline things that they looked at were age, gender, education, income, physical activity, smoking, alcohol intake, history of hypertension, diabetes, and cholesterol issues. They drew several blood panels, and the blood panels that they looked at for these individuals were fasting blood sugar, your basic lipid panel, remnant cholesterol, serum creatinine, that's a kidney function, high sensitive CRP, which is an inflammatory marker that's really specific to the cardiovascular system, white blood cells and neutrophils. I assume they're wanting to rule out infection as a cause to these events, platelets, triglycerides, and a triglyceride to glucose index. So the triglyceride to glucose index is a pretty good indicator of hyperinsulinemia, insulin resistance. Now, it would have been much simpler had they just drawn an insulin level, but regardless, they did a triglyceride to glucose index, which is very sensitive for insulin resistance. They divided these 97,000 people into three groups: those before the age of 55 at the start of the study, those between 55 and 65, and anyone 65 to 75, and then 75 and up. So 4 different groups that they were looking at. At the end of the study, the main findings, so they followed them for 13 years and they recorded how many people had heart events. And I want to say I had that down here. I did. So 7,887 people developed cardiovascular disease over 13 years. So of the 97,841, 7,587 developed a heart event, so a heart attack or a stroke. They presented their findings in a way that was kind of interesting to me. At first, I didn't occur why they presented it this way, and then I think I figured it out. So they looked at clinical risk factors, so the things like their blood pressure, their smoking, current conditions that they had, things like that, clinical markers that would have been on that screening test that would have predicted having heart disease. And what they found is that if you were under the age of 55, your number one risk factor was diabetes. Now, first study, we talked about hazard ratios. And remember, you have to be over a 1 for anything to be clinically significant whatsoever. The further you go over 1, the higher it is to be, or the more likely it is to be related. So the elevation or having diabetes had a hazard ratio of 4.08. So very significant if you are under the age of 55. If you're greater than 55, your number one risk factor was hypertension, and that was a hazard ratio of 2.61. Now, they also did find that this was attenuated with age. What does that mean to be attenuated with age? It means the younger you got diabetes or hypertension, the more likely it was to be correlated or lead to a cardiovascular event. Then they broke it out and they just looked at lipids. And that was what's confused me, that they pulled out just lipids to look at it. And then it's like, well, they're trying to hold on to this paradigm that lipids are the end all be all, or maybe they're wanting to draw attention to something else. So if the triglycerides or if the total cholesterol was high, it had a hazard ratio of 1.33. So it was correlated. If the triglycerides were elevated, it had a ratio of 1.15, so very likely, or clinically significant. And the HDL being low did have a hazard ratio of 1.14. LDL showed no significance. So regardless of what people's LDL, they could not find the correlation with a cardiovascular event. But elevated total cholesterol, elevated triglycerides, and low HDL did see it, but notice their hazard ratios are much closer to that 1 mark than the diabetes or the hypertension ones that they pointed out. Then they looked at metabolic and inflammatory markers. So remember, they did the cardio CRP, and they did that triglyceride to glucose index, which is a marker of insulin resistance. And what they found that overall, regardless of the age, whether you were under 55, above 55, regardless of the age, if you had an elevated triglyceride to glucose index, you had a clinically significant marker that was going to indicate more cardiovascular disease. And that was at 1.42. And then they noted fasting blood glucose was also elevated at 1.31, and high sensitive CRP was elevated as well. Now, these ratios seem quite low compared to the women's study. Could that be that the women's study just had such a much bigger population, and they started with more than double of what this individual study did? I don't know. I'm not smart enough to figure that out yet, but I do know that when I look at a hazard ratio of 4 for diabetes, that's a pretty big hazard ratio compared to something that did not show anything, didn't even make 1 to make the page on the mark. So to recap, the clinical risk factor of diabetes is associated with the highest risk for cardiovascular disease in participants under the age of 55. And in addition to hypertension, metabolic syndrome, which also houses hypertension in it, overweight and obesity, dyslipidemia, smoking were also strong risk factors. Looking at the individual biomarkers, the individual things that we're going to equate to, so the blood markers, the testing they did, the insulin to triglyceride ratio was the number 1, reflecting insulin resistance, having the greatest risk for cardiovascular disease. And they said that these findings highlight the importance of diabetes and insulin resistance as a major determinant of premature cardiovascular disease, as well as other modifiable risk factors that can be addressed with lifestyle. You don't need a drug to fix these. You can use drugs to help them, but honestly, I don't know that there's evidence that taking the drugs to help them lowers your risk of heart disease at all. I have plenty of diabetic patients who their A1C is controlled with medication, but they still have heart attacks. So if you get rid of the diabetes, you reduce your risk of heart attack. So it can be controlled with lifestyle and good nutrition. The study did point out, and they did this at the very end in the conclusion, which I thought was kind of sneaky. They pointed out that most lipid profiles and metabolic profiles and inflammatory biomarkers were associated with risk, just not as much as the triglycerides. So there's still risk. They're still part of the forest. They're still part of the story. But here's the thing. For years, we've been a whole bunch of Winnie Poohs looking up at this honey tree of LDL cholesterol, thinking it is the end all be all and it's going to give us all of our answers of cardiovascular disease. And we missed all of those other trees in the forest. So we really got to quit being Winnie Pooh and going after honey and get rid of our insulin resistance, get rid of our diabetes, get rid of these hypertension, the metabolic syndrome, the things that are in the forest that have higher hazard ratios, higher risk of heart disease. So if you don't want to die of a heart attack, you don't want to have a stroke, then you need to get your insulin under control. You need to get your weight under control, get your high blood pressure under control. And when I say under control, I don't just mean taking a drug and putting it in the quote normal ranges. You need to make the hard choices and the hard work to change what you're putting in, how you're sleeping, how you're moving, your stress levels, all those things that we teach here in the clinic, because they go into this insulin resistant picture. Because I'm telling you, when someone dies at a young age of cardiovascular disease, it is just devastating. It is devastating. I've seen it firsthand, and I know you guys have too. So don't let that be you. Don't let it be your family. Change and be healthier. And if you know someone, male, female, who needs to hear this message that, hey, just because you went to the doctor and your cholesterol was good and in normal range, don't think that that's going to be saying you're safe. Go have further testing and know that you are not insulin resistant. You're not pre-diabetic. And in our clinic, I like to get fasting insulin levels. I like to get C-peptides. I will get a triglyceride and a glucose, so you can look at that triglyceride to glucose. We get a measurement of your visceral fat, which is talking about the fat that's trapped in the organs. The more visceral fats is there, the more likely you are to be insulin resistant. So there are good tests that you can do, and they're not typically done in your general physical, but they're out there. And if your provider won't order them, we're happy to work with you to order them for you, or you can even look at ordering them yourself at a place like Own Your Own Labs. All right, guys. So next week, I'm really hoping to get to a study on nattokinase, which is a supplement that I've recommended for heart disease. It's something I've been meaning to get to for a while, so stay tuned for that next week. Low carb for better health. The tickets are up and for sale, and we do have cholesterol experts coming this year. We've got Dr. David Diamond, who is, in my opinion, one of the premier cholesterol experts, and Dr. Philip Ovadia, who is a cardiovascular surgeon. So there will be good people to give you more information than I personally can give you on these little shows here that we do at Low Carb for Better Health. And you can find that at www.lc4bh.com. Go ahead and get your tickets, get signed up. It's September 12th and 13th. I can't wait to see all you guys there. All right, so until next week, be happy, be healthy. And if you're in my area, be careful because the snow is coming. Bye.